Hi, listeners. John Pallies joins us today. He's the Chief Financial Officer for John Brooks Recovery Center in New Jersey. We're doing a mental health business podcast, and we finally found someone that we could go back and forth with around value-based payment. So this is a win for us, and hopefully it is for you as well. Mr. Pallies has more than 20 years experience as a senior financial manager in nonprofit organizations serving low-income populations experiencing challenges with homelessness, mental health, and addiction. He has a Master of Science in Management from the University of Pennsylvania, a Bachelor of Arts in Accounting from Rutgers University, and is a certified management accountant. Thanks for joining us on this show today. Enjoy.
I'm not the house of cards that falls down easily. Oh, I'm strong enough to handle what you throw at me.
Welcome to Mental Health News Radio. I'm your host, Kristin Sunanta Walker. Just what are we going to discuss? The intimacy that is mental health. Let's continue to make it as comfortable as discussing brain health or heart health. This show has been on the air for several years, and we have amazing co-hosts. And then we created a network of podcasters on mentalhealthnewsradionetwork.com, a place where every possible facet of mental well-being can be talked about openly. My show, after several hundred interviews, the format is this: intimate, deep, funny, touching, sometimes uncomfortable, but always vulnerable conversations with interesting people. The goal is to have you, our listening family, many of you who have become my good friends, feel as though you are listening in on private conversations. Thank you for tuning in and becoming part of this amazing journey with me, and now with our network of podcasters. Just knowing this podcast might be helping any of you realize you are not alone on this journey called being a human being makes doing this podcast worth every second.
After all we promised, we'd be cordial.
John, good morning. Thanks for coming on Mental Health Business Podcast.
You're welcome. Glad to be here.
Yeah, and Dave, thank you for joining me, my trusted co-host.
Yeah, well, I'm glad to be here too.
So what we do, as I had said, John, on this particular series is we really get into the guts of working, the inner workings and the business side of mental health. So what I wanted to find out from you is, you've been a CFO for a long time. You have more than 20 years of experience as a senior financial manager in nonprofits. So what have you seen in terms of how the money flows in mental health and nonprofit agencies? What have you seen that's been a significant change over the last 20 years?
So, 20 years ago, I've only been in mental health for 10 years, but before that I was in medical research. But 20 years ago, even less than that, 7, 8 years ago, everything was funded by grants. And grants are good for startups, but they're not that good in the long run because it kind of forces you to the bottom line. It doesn't encourage excellence in treatment,
right,
or in best practices. So the states and federal government have struggled to move people away from grant funding as far as long-term funding of programs. So the first step in that, when I was in a mental health clinic in Bucks County, Pennsylvania, about 9 years ago, I started there. They were just moving to fee-for-service and Medicaid and Medicare. We actually took all and some private insurance. So they went from funding it with grants to funding it for a payment for a transaction. And that was a huge change for these nonprofits, particularly, who weren't all that geared towards running their operations in a business-like fashion. Because no matter what they did, they couldn't make money. No matter what they did, they couldn't lose money, because if they, needed more money, the grantor, the funding sources would just increase their grants. If they lost money, they couldn't make money because the grants would only reimburse for actual expenses that they could prove. The problem with that is things don't always go well in any kind of organizational structure. And the grant funding model didn't allow for any kind of contingencies for periods where things didn't go well, where you lost money. And every, business / organization goes through periods where they don't meet their projections and things happen.
Especially in mental health. Yeah.
Yeah. And actually any business, you plan for the future, but you can't plan for every contingency.
Right.
So you're going to have periods where you lose money, and grant funding didn't really take that into account. It was kind of blind towards that. So these nonprofits, for the most part, made that up through fundraising, which is fine. And I think you need to do fundraising, but the real problem was there was no incentive to run in a business-like fashion, and it was hard to push these mental health agencies to adopt measures for excellence that weren't necessarily financially beneficial to them. So the move towards fee-for-service reimbursement was a step in the right direction, especially at John Brooks Recovery Center, where that happened about 4 years ago, maybe a year before I got there. The fact that they ran it in a more business-like fashion made a big difference. They made money as they moved into a fee-for-service arena, whereas a lot of not mental health especially, but substance use also in the state of New Jersey, they lost money in the fee-for-service arena and had to go back to the state and ask for help, which the state did. They put together a program to reimburse these mental health. They were mostly mental health nonprofits that lost money in that transfer, but we didn't, and so we were ahead of the game in that respect. And that's always been my approach since I got into the nonprofit world, was to adopt business-like methods, because organizational dynamics in every type of operation are pretty much the same. It doesn't matter what your mission and vision is. The dynamics among how people behave are identical. So you need to have the same kinds of methods, just a different, mission. The outcome's not to make money; it's to provide excellent care.
Right.
So now we're in an environment where fee for service is again not pushing the envelope far enough, especially in the substance use disorder field.
Right.
Obviously, payers and governmental agencies they don't have as much pressure points on these opioid treatment agencies and substance use treatment agencies, because we've got 1,000 addicts coming into our office every day getting methadone.
Right.
So what are you going to do? Threaten to shut it down? You can't.
Right. You can't do that. Exactly.
They can't, and to some extent we've used that to our advantage in the past, but the move now is towards paying for outcomes, and they've moved that faster in mental health. Actually, physical health, most payments in the state of New Jersey are for outcomes. In other words, you get a transaction payment for doing the office visit or a test or whatever you do, but then you also have a contract with Centers for Medicaid and Medicare, or with private insurance companies that say if you meet certain outcomes like reducing hospitalization or emergency room use in your area, or reducing re-hospitalizations and numerous other factors, you'll get a payment at the end of the period. And you're part of a group, a consortium of large providers of services that will receive your portion of that payment.
Interesting.
And it's been, in Bucks County about 4 or 5 years ago, they started to move in that direction by requiring everyone to have a CMS certified, Centers for Medicaid and Medicare certified electronic health record, which had the metric tracking built into the billing system.
Right.
So they start with a carrot and end up with a stick. They put together teams of providers, mostly nonprofits, to develop what the metrics were going to be that they were going to pay for performance on. And then over time, they reduced the Medicare and Medicaid payments to where you couldn't really be profitable. The other thing that you might not think about as you're looking at that process is, unless you're a significant player in the market, they're not going to be interested in contracting with you. So you're going to be stuck with these lower per transaction fee for service payments, and you're probably not going to survive. So it's forced some, consolidation.
Right.
John, are you also experiencing that they're expecting the provider to assume more risk?
Well, absolutely, because they're, now if we do a visit, we get paid X dollars. It doesn't matter if we do a good job or not. It just matters if our electronic health record shows, 45 minutes or whatever the Medicaid requirement is, and that we do a treatment note, even if it's not a great treatment note, and then, we bill it, whatever other factors are in the Medicaid rules. Usually most companies follow Medicaid. We're going to get paid.
Right.
Under the value-based payment model, unless you meet the outcomes, you're not going to get paid. You'll get some payment for the visit, for the transaction, but it won't be enough to sustain you as a long-term organization.
Some of that's going to be driven by program, and also by the way people chart and keep track of the care plan.
Well, it's everything affects it. You have to do research and figure out what are the evidence-based treatments that have a better chance of statistically providing the outcomes you want. Every individual's not going to reach the outcome, but that's the issue. It has to be on a larger scale in order for it to make sense for the payers.
Right. No, absolutely. I see that happening all over in the different states, that we work in, particularly the risk piece. I was at a conference in Washington where they talked about the fact that a lot of the smaller agencies are not going to be able to sustain the risk because you have to have some money in the bank to back yourself up. Are you seeing that too?
Well, that's so yes, there's no question. I mean, that's an issue because they are shifting the risk and the reward to people that take the risk and are successful. But really so size is an issue for that reason as well in mental health. Also, you need to be able to move the needle epidemiologically. And if you're small potatoes, seeing a few hundred clients, it's not gonna have an impact that they can see within their geographical area that they're paying for performance, paying for outcomes. So that they're both issues that work against smaller providers unless they have some unique skill set treatment that's been proven to be better than others. Because that leads me to the other issue. It's especially relevant to substance use. So substance use, you may know this, in this progression from grant funding to value-based payments is behind everybody. It's well behind mental health. Right. But one of the problems with substance use, if you think about someone who suffers from substance use disorder and something triggers them to go to their doctor or to an emergency room, if you go to 10 different emergency rooms, you're going to probably get 10 different episodes of care. It's not like if you had a broken leg or diabetes, or if you went to 10 different doctors or emergency rooms, pretty much the treatment's going to be pretty similar. And whoever's treating you is going to have a continuum of care that's going to cover all the bases. Absolutely not the case in substance use. You go to your one local emergency room, they're going to give you a shot of buprenorphine. If you go to another one, they're going to send you to an AA meeting. Yeah. It's all over the map.
No, absolutely. No, you're right in terms of what happens. And if the patient goes someplace else, and then they get into their kind of line of care, that's another line of payment.
Well, that's true too, but it depends on their insurance.
It does, yeah.
And that could affect what treatment's recommended too, and that's a problem. And the people that understand what's going on in substance use realize that this is a huge problem, because even if you're Thomas Jefferson University hospital system, you don't have the continuum of care. If, for example, in our geography, AtlantiCare, they're the biggest healthcare provider in Atlantic County, New Jersey. They don't have every piece. They don't have sober living houses. They don't have community outreach. They don't have a methadone clinic. They don't have intensive outpatient. They have some pieces of it, and we don't have an emergency room. We're just getting into physical health. And even executing our vision, which is to provide physical health services for our clients, we're not going to treat, broken legs. We're going to treat what our clients have, because we know it improves outcomes. If we tell the client, oh, you have high blood pressure, go see your doctor, they don't do it. Right. Even if we had a doctor across the street, they wouldn't do it. But if we can send them down the hall to our doctor, which is what we're going to do, we can make sure they get treated, regardless of whether we get paid or not. We're not even concerned about that, although we did just get a grant to start doing this. But so our vision is to figure out who to partner with to normalize the continuum of care for each diagnosis that the clients that come to us, that we may provide to them, and be able to identify which of the partners provides which of the services that are in the continuum of care, or the episode of care, however you want to call it, for that particular diagnosis for that client. That's the challenge for us.
Yeah, that becomes a big challenge. I know we have a program in Arizona that has what they call value-added partners. Who, when someone comes into their clinic, that there's something that they don't do, because value-based payment kind of says you have to pick out the thing that you do the best, and then that's what you do. And then everything else is like what you're talking about, where maybe agency Z over here does something and that patient needs that, which also that creates a challenge in relationship to treatment and the treatment plan.
Right.
Because if you send them off to agency Z, you're still going to be accountable for what happens.
Right.
Now,
so part of the answer to that are these health information exchanges, and the requirement that everybody has an ONC 15 certified medical health record.
Right.
Because ONC 15 sets the standards for interoperability. So the state of New Jersey came out with a program last year. There's 129 substance use disorder, OTP, opioid treatment programs in New Jersey. And they offered, they created 5 milestones. And the first milestone, and they offered incentives to reach each milestone. The first milestone is simply to sign a contract with a company that markets an electronic health record system that's ONC 15 certified. It's been a dismal failure. I don't know if they've had 10 people sign up. It's been a dismal failure for a lot of reasons. But to me, the most interesting thing about the 5 milestones is only 3 of them exist. The other 2 are pie in the sky health information exchange. Everybody's guessing where that's going to go. I mean, they know where they want to go, but it doesn't. It's vaporware at this point. So I thought that was kind of interesting.
Yeah, all those things make it hard, because what I'm seeing in states too is that although they want to go to value-based payment, they're not changing any of their funding rules.
Right, that's not going to work.
Yeah, the rules aren't keeping up with
it's not going to
where
work.
they want to go and the changes. And even, for Medicaid, that's a problem too. Washington's not keeping up with what it is they're expecting providers to do, or states to do in relationship to value-based payment. They all want accountability, but none of them have.
They don't seem right. And they don't seem to have leverage to get them to do what they know these nonprofits need to do, but they don't. Especially in the substance use disorder
Yeah.
I mean, they just don't have the leverage.
Yeah. Substance abuse is a different world, in terms of treatment and
It is.
what goes on with people. I know when I started in this business, you went to a residential program. The one I worked in,
Right.
people were there an average of 3 years.
Right.
Now you're lucky if you're there an average of 30 days.
Yeah, it's more like 3 weeks. Right.
Yeah, and then sometimes you can get detox, and that's like 3 or 4 days. And then, yeah, you've cleaned up in 3 or 4 days. No, I shouldn't say cleaned up. You've quit using for a few days. And now you're expected to find your way to a treatment program.
Yeah, and a lot of people think that if you go into medication assisted treatment, that you're still an addict, and they don't think that you're really being treated.
Yeah, I know, and that drives me nuts too.
It's crazy.
Yeah, I know.
Because that's a revolving door. Those people are back in there, 4 or 5 times.
Yeah. Of course, nobody wants to give them a job. Nobody wants to, it's the same old thing. We're not doing anything to change the perception in terms of what that means, when you go to a program where you're going to get assistance with medication.
Yeah, they're trying in New Jersey. So whenever they come out with new programs, new grants in New Jersey, they require in the application, you have to certify that you'll allow people that are on medication-assisted treatment into your program. So that they're trying to. I mean, they get it. At least the state of New Jersey gets it. I mean, SAMHSA gets it. Everybody knows that this is evidence-based.
Yeah, I mean, all these governmental groups, they don't talk to each other. So nobody really knows what's going on. They just know they want value-based payment.
Right.
Yeah.
Right.
And then that presents a tremendous challenge to the provider. And you're right, size makes a difference. And, clinically, that must provide a challenge for your agency too, in terms of people coming in for therapy.
I'm not sure exactly what you mean there.
Well, people coming in for therapy in relationship to being able to track it and to be able to demonstrate that they're actually getting better.
It's very hard because once they leave, we have a hard time following them. The state has a database, New Jersey Substance Abuse Management System, that's supposed to do that, but we don't have access to the data after they leave, and it's a pretty outdated tool. I mean, their final milestone is to replace that of the 5 milestones, but it's just been. I mean, the organization that provides authorizations through that system is called the Interim Management Entity, because they couldn't commit to doing it permanently, and it's been the interim for 5 years. So it's ridiculous.
Yeah, but seeing that in a lot of things like that in a lot of states, not just in yours, in terms of the way this is going. Michigan's still very invested in fee for service. And even though the governor says we're going to value-based payment, I haven't seen it. That's a challenge. And there's a lot of states in that position.
Yeah, it's hard to, it's hard to put in substance abuse especially, it's hard to create those episodes of care, but they're going to have to do it. They're going to have to define, for this diagnosis, what's a typical episode of care. I mean, they've done it in some places for mental health.
Yeah.
And that's the way it has to work. You have to say, if you're diagnosed, with opioid disorder, you've got to do these different things over X period of time.
Yeah.
And these consortiums have to figure out who's going to do which piece.
That's right. And that is extremely hard, because
it is.
What you see out there is that on a fee-for-service model, what we see in agencies, and we saw this in Iowa, is that we'd ask them how many, what's your program? And they'd say, well, we have 14 programs. I said, 14 programs, and how does that work? Well, that's how we get paid.
Right. They chase the money.
Yeah, Joe Smith into 8 of these, then we get paid for everyone that he's in based upon service delivery. I said, well, that's an interesting way to do it. But, you run into that, and that's kind of what fee for service has driven agencies to.
Right.
You create
Exactly.
all these things, and then
Exactly.
then it becomes extremely difficult to run them all.
Well, it's extremely difficult, but the worst part is it's not effective in terms of outcomes,
No, as far as treatment, no, it's not. No.
and it's not cost effective. You look at detox, people that detox and don't go into medication assisted treatment. It's just a money machine for the detox
Yeah.
providers.
Because they keep coming back.
They keep coming back for $450 a night. It's just
And the beds are never empty.
right. Never. It's a great business, but it's
Well,
not
it
helping,
is.
outcomes.
We have an agency in Indiana that has a detox program, and it's the Salvation Army. And, they're at the point where they're going to increase their detox program and decrease everything else because it's the only thing they get paid for.
Yeah.
So it's very difficult. So there'd be some big challenges ahead.
You know what I find interesting listening to the two of you, and John, you don't know this, but Dave has been telling me we need to get someone on the show to talk about value-based payment. We need to get someone that knows what they're talking about. So I'm sitting here smiling, listening to the two of you because, John, you know what you're talking about.
Yeah. Well, thank you. I think I do.
I think it takes, coming at things in substance use disorder and also in mental health, coming at things from that business perspective when it comes to the financial management of an organization. Because if you're mired in it as you get from the clinical side, that uses a different skill set than what's needed to pull back and see it from an operational side. And, you've got that. So that's good. This is the kind of thing that people need to hear about that are getting into the field now and have no idea what's going to hit them when it comes to all of what you're talking about.
Oh, that's right.
Yeah.
Yeah, therapists are not being trained yet in graduate schools on what exactly is value-based payment. What's that look like in relationship to your services?
Exactly.
That's not happening. You got a lot of professors still teaching the same old stuff that nobody's going to be using anymore because they can't afford it.
Yeah. I mean, we until recently, we had a recent change in senior management. We were doing the same thing for 50 years.
Yeah.
And it was, and really the goal was to how do we get paid? But and I think we've replaced that with a new model, which is our vision is how do we provide the best care that produces the best outcomes for these clients? And how do we figure out how to build out the continuum of care that it requires to have a complete, step-by-step episode of care for every type of diagnosis. So, and it's not so that we can get paid. If you keep your eye on the patient outcome, we believe you're going to be financially successful. Run it like a business, except that your vision is excellent care and good outcomes rather than making money. And I think if young people getting into the field understand that and approach their jobs that way, they're going to do a better job. I mean, we have counselors that when clients show a disinterest in attending sessions or doing what program calls for, they write these people off and say, well, when you're ready, come back. They're the people that need the help the most.
Well, that's right. And
like you said, these people coming out of college, they don't understand that.
No. All of them want to be. I always get it. I supervised graduate students for a number of years, and I'd always used to ask them. I said, "Well, what do you want to do when you get done? You get your degree, you get your license." Well, I want to be a private therapist. I said, "You want to be a private therapist?" what makes you think you have the experience to be a private therapist to anybody? Well, I'll make a lot of money. I'm like, yeah, really? I owned outpatient clinics. You're not going to make a lot of money.
No. No.
No, but you're right. I think the direction you're going in is absolutely the right one. You know, and there's some big challenges in there, but I think they can be met. Other places are doing it, and I think we'll get there. It's just you got to change the mindset of an entire industry.
Yes.
Which is very hard.
It's unbelievable to me that the state offered, these incentives to 129 OTPs and hardly any organizations took them up on it. It's just amazing to me. Mm-hmm. They're just so set in their ways.
Oh, yeah. Yeah, they're still doing things the same way.
They're so set in their ways. And they don't see the danger that's going to wipe them out. They just don't see it.
I know it.
And it is going to wipe them out.
Yeah, they're going to be gone.
It's coming, whether they get on board or not. It's coming.
That's right.
Well, I'm glad the two of you are talking about it, because we do have a lot of people tuning in that tune in just to this series, and they are listening in to hear about things like this to hopefully, at the end of the day, what we're trying to do here, we're not making widgets, and I know widget making is important, but these are human services. They're needed so people survive. So there has to be information that we put out that helps these people stay in business so that they can continue to provide human services.
Mm-hmm.
Yes. Mm-hmm.
That's right. Because as John said, and I agree with him, things are changing. They're not going to stop. They're going to keep changing.
Well, John,
it has to. We got to spend this money more efficiently.
Absolutely. Yep. Tell our listeners, John, where they can find out more about your organization.
It's www.jbrcnj.org.
Fantastic. Well, thank you for coming on.
Thank you for having me.
Absolutely. And Dave, as always, thank you for chiming in. I knew on this particular show you would have a lot to say. And listeners, thank you for tuning in to another episode of our Mental Health Business Series on Mental Health News Radio. Hi, listeners. I'll make it quick. These are some really cool places that give discounts and other cool things for listeners of Mental Health News Radio Network. If you want to get amazing help with healing from narcissistic abuse, go to healfromanarcissist.com. If you want CBD products that are the best of the best, I use them myself, go to proze.com and use the code mentalhealth20, mentalhealth20. If you want to get daily perk ups that help retrain your brain to think more positively, go to perkupdaily.com. And also, just because this one's fun, snarkycandles.com. I guarantee you'll love them. Snarky with a Y, SNARKY, candles.com. And don't forget, if you want to hear all the shows on the network about first responders, you can go to firstrespondermentalhealthnetwork.com, and all of our shows that focus on narcissistic abuse, narcissistabusehealingnetwork.com. Thanks for listening, and back to the show.
Sometimes I'm passive-aggressive, but never without good intentions. I heat up and act on my emotions.
Thanks so much for listening to Mental Health News Radio. Our podcast can be found on iTunes, Stitcher, and hundreds of other podcast apps, or you can visit our website at mentalhealthnewsradio.com. If you have a question or would like to be a guest, become a podcaster on our network, or join the amazing organizations that help keep us on the air, please email us at info@mhnrnetwork.com. Get ready for that special goodbye from our resident therapy dog, Miles, and a special thanks to Emily Sohn for letting us use her incredible song, Cordial, for our podcast music. Listen to the full song on SoundCloud at emily.sonne.
Don't be surprised when I don't hate on you. After all we